Okay, good afternoon, everyone. It's 2:01, so we try and stick to the time. Thank you so much for being here for the last session of the conference. I'm surprised that we have so many of you here. Hersh and I thought it was going to be just me, him, and Khaled is coming later. So thank you for being here and listening and discussing and asking questions and having such nice interactions with us. Before I introduce Hersh, I remind you last session of the conference, but we are meeting again next year in Menton, south of France. So by all means, whoever can make it, please be there. We're all going to be there. It's going to be a fun conference to hope to see you all there. So without further hesitation, I'll introduce Hersh Chandarana from NYU. He's going to start it all off with multiparametric imaging of renal tumors.
Yeah, I echo the sentiment. Thanks for staying back for the last talks. Considering it's a small group, I'll give my talk and maybe take some questions after that if you can finish in time and then go on. So what I'd like to do is to talk about just my disclosures, talk a little bit about a paradigm shift in management of renal cancer, and then role of MR imaging from a problem-solving tool to actually a baseline tool that allows you to go beyond providing information about the cancer or not a cancer, but to try to guide the way the therapy is changing. So our current role as a radiologist is basically to say, do I detect the renal mass? And if I detect the renal mass, is it a cancer or not a cancer? And if it's a cancer, then we provide preoperative planning and staging. Our evolving role, and I think this is not too far off, is to provide information about personalized treatment. What do I mean by that? Well, what I'm able to provide information about not only cancer or a cancer, but also provide information about what subtype of cancer it is. Is it aggressive tumor? What is the degree of aggressiveness? And is the patient going to benefit from surgical therapy? And to do that, I need to provide information also about renal function. And so if I can do both of those in a one single exam, in a one single tool, they can allow personalized treatment based on tumor aggressiveness and renal function. So let's take a look at this usual case that we see all the time. Patient comes in for right lower quadrant pain, gets a CT exam done for rule out appendicitis, small bowel obstruction, something of that order, and we find a 1 centimeter incidental lesion in the right kidney here. So this is a 1 centimeter lesion in a patient who's asymptomatic. The question is this a cancer? Not a cancer? Is the patient surgical candidate? The decision at this point, we are unable to discriminate aggressive from indolent tumors, especially on a CT imaging. And as a result, surgery is a first-line treatment. And you'd say, great, surgery is a first-line treatment. What's the problem? Well, the small renal cell cancer account for almost $3.5 billion in cost in healthcare in the United States. And more importantly, although it provides a great oncologic control, it's a great cancer therapy to remove that kidney or part of the kidney that has tumor, but it's associated with development of renal insufficiency and cardiovascular morbidity and mortality. So it provides good oncologic control, but has a lot of side effects. So this was a study that's really interesting, and it was published it's being submitted a while ago in JAMA. And basically what it shows is that if you take all these patients, some of them are poor surgical candidate, so they didn't go to surgery. They were either managed with the non-surgical options, including active surveillance or watchful waiting. And the patients who couldn't go to surgery initially had a higher mortality. But over time, the mortality actually was less than patients who underwent surgery over time. And what this tells you is that surgery is not answer in itself. There's something else going on here, right? There are patients who have aggressive tumor who really benefit from surgery. But there's a subpopulation of patients who actually don't benefit from surgery or not as much benefit from surgery. So the idea here, the changing paradigm is that if I can actually select patients with aggressive tumor, those that are going to benefit from surgery, and select them for surgical treatment and while not doing surgery in indolent tumors, that would be great. That would provide a better way of managing these patients. So let's start at how we deal with this. So again, the first question we try to answer is it a cancer or not a cancer? And almost not, the way the conventional teaching is that non-fat containing enhancing lesions are deemed malignant and hence surgical. So if the tumors don't have bulk fat, and if the renal tumor is enhancing, because we can't assess for aggressiveness, we're going to assume that this is an aggressive tumor and it's surgical. So our goal has been to detect presence or absence of enhancement and macroscopic fat. The tools that we have is ultrasound, CT, and MRI. PET's not routinely used as a first-line therapy or even a second-line, first-line agent or second-line diagnostic tool. In the United States, contrast-enhanced ultrasound is relatively new. It's only been approved for over a year, so we have very limited experience and personally with contrast-enhanced ultrasound. So what I'm going to talk about is CT and MRI. And the MRI has always been used as a problem-solving tool. It's been used to detect enhancement in small and calcified lesions where it outperforms CT, and it's better characterization of a lesion as solid or cystic. But as I mentioned earlier, with this changing paradigm, there's actually a role for doing much more, providing information about aggressiveness, histologic subtyping, and functional evaluation. And here, MRI has strength, and we can take advantage of those strengths to answer those questions. So our protocol on MRI includes in and out of phase imaging, to do chemical shift imaging to look for intravoxel fat and bulk fat, do a T2 single shot FSE sequence, we do diffusion with imaging, and then we do T1 pre and post contrast imaging in multiple time points after contrast injection. So we, in the same situation, we are able to not only assess for presence or absence of renal mass, assess for presence or absence of enhancement, but having multiple phases of enhancement allows us to do preoperative planning, assess the location of that lesion with respect to vessels and ureters. And I'll show you some more example of that later. So how do we assess for enhancement? As you all know, mostly we do it qualitatively. So you acquire, this is a pre-contrast image, and this is a post-contrast image after injection of intravenous gadolinium. And there's a left renal mass that demonstrates increase in signal intensity after contrast injection, compatible with an enhancing renal mass. And it works most of the time, except when you have a hyperintense lesion. So this is a right renal cystic lesion with a nodule. This nodule is T1 hyperintense on a pre-contrast image. So there's a high signal before you give a contrast. And on a post-contrast image, visual inspection sometimes is not helpful in detecting presence or absence of enhancement. So two ways that we can deal with this. One is to put a region of interest and assess for change in signal intensity from pre to post contrast. And studies have shown that 15% change in signal intensity is compatible with enhancement. One thing to keep in mind when you do that is that you need the same protocol, the same acquisition parameters for pre-contrast and post-contrast images. Right? As you all know, in MRI, signal intensity is not based on a physiologic property. It changes when you change your acquisition parameters. So if you change your TR, you change your TE, you shim in between, all those things will affect your signal intensity. So if you really want to use this method, I think it's advisable to have the same pre-contrast image and actually just copy that acquisition again after contrast injection so you avoid any change in acquisition parameters. Another way to do this to do subtraction imaging. It is to take a pre-contrast image and subtract it from a post-contrast image. An idea here is that if you subtract pre-contrast from a post-contrast image, only difference that you would see is because of contrast injection. And almost all scanners now can do that automatically in line and do a voxel-wise subtraction. So if you have a pre-contrast image, a post-contrast image, and a subtraction data set. And the subtraction data set is subtracting voxel-wise pre-contrast images from a post-contrast image. So anytime you see high signal, it's because of presence of gadolinium. And so this cystic lesion here has this nodule that demonstrates enhancement. It's a cystic renal cell cancer. Evaluation for fat. Well, the way we can do this is two ways. One is to do frequency selective fat saturation either on T1 weighted images or on T2 weighted images. So you acquire a T1 data set or T2 data set without fat suppression and then with fat suppression. And if you do that, and if you lose signal, that's because of bulk fat. Presence of bulk fat is diagnostic of angiomyolipoma in almost all cases. There have been few handful of reported cases of clear cell cancer or other cancer types that may contain some bulk fat, but that's either because of that encasing the fat and so on, but almost always, if you detect bulk fat, that's a benign lesion, angiomyolipoma. On a post-phase imaging, that's when you do in-phase and out-of-phase imaging. Signal loss and out-of-phase acquisition is compatible with microscopic or intravoxel fat. That's not bulk fat. So signal loss and out-of-phase images is not diagnostic of angiomyolipoma. Let me show you some example. So here, you have an in-phase image, and then you do frequency selective fat suppression. When you do frequency selective fat suppression, all the fat, bulk fat, loses signal. So the subcutaneous fat loses signal, and this lesion that contains fat also loses signal. This is compatible with angiomyolipoma. On an out-of-phase image, you don't lose signal because in out-of-phase image, you only lose signal with microscopic fat, not bulk fat. But what you see here is so-called India ink artifact. Any voxel that contains water and fat loses signal. So if you see a India ink artifact, you know that one side of that line is bulk fat and the other side is water. So if I know that my kidneys is made up of water or soft tissue, this has got to be a fatty lesion. Right here, it's an India ink artifact, which means that this lesion here has a bulk fat, and is an angiomyolipoma because you need this India ink artifact. In this case here, you have an in-phase image and an out-of-phase image. You lose signal on out-of-phase image. This is not containing bulk fat, right? You don't see the India ink artifact. What you see here is microscopic or intravoxel fat. Now, the differential diagnosis here is an angiomyolipoma, but also entities such as clear cell renal carcinoma that can have signal loss on out-of-phase images. You've got to look at your other contrast. So you see that the same lesion is heterogeneous T2 signal and heterogeneous enhancement. Heterogeneous T2 signal and heterogeneous enhancement favors a clear cell subtype of renal cell cancer. Angiomyolipoma tend to have a homogeneous T2 signal and homogeneous contrast enhancement. So if you see a lesion that has a signal loss on out-of-phase images, but on a signal intensity on T2 is heterogeneous, or it contains hemorrhage, or the heterogeneous enhancement, that's not an angiomyolipoma. That's a clear cell subtype of renal cell cancer. On the other hand, a homogeneous lesion, homogeneous T1 signal, homogeneous T2 signal, homogeneous enhancement, no hemorrhage, no calcification, no necrosis, and signal loss on out-of-phase image on a patient population that favors the possibility of angiomyolipoma, you can suggest a diagnosis of an angiomyolipoma. Studies have shown that on diffusion-weighted images, angiomyolipoma tend to have lower ADC compared to clear cell and other subtypes of renal cell cancer. The ADC may overlap between angiomyolipoma and papillary subtype of kidney cancer, but if you can actually differentiate between those on different other signal characteristics that we'll talk about. Other issue that we deal with differentiating benign from malignant lesion is oncocytoma versus chromophobe subtype of renal cell cancer. A lot of studies have shown that central scar or other things like signal inversion can favor a diagnosis of oncocytoma. I can tell you in our practice sometimes we can't differentiate between oncocytoma and chromophobe subtype of renal cell cancer. One of this lesion is oncocytoma and one is a chromophobe. And I actually can't even remember at this point which one is which, but they have same morphologic features. If you just use morphologic features such as central scar or segmental inversion, you'll be wrong sometimes. You favor diagnosis of oncocytoma, but you really can't be confident that it's not a malignant lesion. Even at biopsy sometimes, there's difficulties in differentiating oncocytoma from chromophobe subtype of renal cell cancer. Other area that you want to be very careful about is differentiating central renal cell cancer from urothelial cancer. And the reason is that if you have a central renal cell cancer, the treatment is removing of a kidney, either partial or total nephrectomy. But if it's a urothelial tumor, the surgical approach is to remove the kidney and that ureter on that side. So if you can make a diagnosis of a central renal cell cancer, but it's a urothelial tumor, your surgeons will not be happy because they have to go back in and remove the ureter on that side. So if you have a centrally located lesion that is a homogeneous T1 signal, homogeneous T2 signal, low ADC, restricted diffusion with low ADC, and if you can't be sure that this is a central renal cell cancer, you may have to suggest a possibility of a urothelial tumor. And when you do that, your surgeons will do a frozen section at the time of surgery. And if it's a urothelial tumor, they will complete the surgery by doing both nephroureterectomy, so remove the kidney and the ureter. If you don't do that, then they will have to go back again and remove the ureter. So again, the things that favor possibility of urothelial cancer, the centrally located tumor with a defect. If you see a defect in collecting system, great, problem solved. A homogeneous enhancement, homogeneous signal on T2 images, low ADC, and hypovascularity. All those favors urothelial lesions. And if you favor a diagnosis of urothelial tumor, and you still may be wrong, but at least you'll guide your surgeon in the right surgical approach. Again, this just says that if you see a homogeneous low T2 signal and homogeneous low ADC, you can favor a urothelial tumor for a centrally located lesion. So again, our job is not to differentiate, or not only tell them it's a cancer or not a cancer, but then to provide preoperative planning. There are multiple ways the surgeons approach a kidney tumor. They can do a total nephrectomy, that's remove the entire kidney, or a partial nephrectomy, remove portion of the kidney that contains tumor. And you can either do an open surgery or laparoscopic surgery. When you do an open surgery, you have ability to cool the kidney. So when you operate on a kidney, it's a very vascular organ. The surgeons will clamp the arteries and vein while they remove the tumor, which causes hypoxia in the kidney. When you do laparoscopically, there is no way to cool the kidney. So when you're clamping the kidney, your kidneys are getting hypoxic. If you do open surgery, you can cool the kidney and you eliminate or at least alleviate the effect of hypoxia. So what our surgeons want to know is that how complicated is the surgery? If so, it's going to be a long, complicated surgery, they don't want to do it laparoscopically because it causes a hypoxia time to be long. On the other hand, if it's going to be simple, easy surgery, they don't want to do open surgery because the hospital stays longer with open surgery. A laparoscopic surgery is fast and easy, and if it's going to be a quick surgery and hypoxia time is going to be short, then they would prefer to do a laparoscopic surgery. So some of the information they want is anatomic information about where the tumor is located, how endophytic or exophytic the tumor is, how close it is to a collecting system and a vessel. And one of the scoring systems that's been proposed by the group at Fox Chase that our surgeons like is so-called renal nephriometry scoring system. And what it does is it gives you points based on morphologic features. So the tumor is small, you get less points, and as the tumor gets larger, you get more points. More endophytic it is, it gets assigned more points. More closer it is to a collecting system, it gets more points. So higher the score, more complicated would be that surgery. And so as a result, surgeons have a different way of trying to figure out if they're going to do an open surgery or laparoscopic, or going to be partial or total nephrectomy. And it's more than that. So not only they will like the scoring system, but they actually want to be able to do a preoperative planning based on that. So for example, both of these are T1A, which is less than 4 centimeter left renal cancer tumor. This is a easy surgery because it's mostly exophytic, small tumor in the upper pole. This would be a chip shot for most surgeons for partial laparoscopic surgery. This, on the other hand, is a centrally endophytic tumor. It's not only just endophytic, but it's actually extending into the renal pelvis. This is not going to be an easy partial nephrectomy. It might not even be a partial nephrectomy. This might be a total nephrectomy. So just describing a 3 centimeter or a 2 centimeter tumor in the left kidney is not enough for the surgeons because they want to know how they can approach this tumor. So they like to get the score, they like to look at the images, but actually what we find over time is they actually like the ideas of advanced visualization, using things like 3D printed models, an ability to look at this and hold it in their hands and look at the relationship of the tumor with respect to the collecting system, with respect to the vessel, can improve ability to maybe better visualize and better plan the tumor surgery. Again, this is more in a research setting. We're testing some of these things, but you can do 3D printed models. You can do, for example, HoloLens. This is a holographic image of a cancer. It's actually in my PhD student's room, and it's basically looking at a holographic image that the surgeons can rotate, can actually feed into their surgical robot, and then again actually help them plan better the preoperative planning. So again, this is where I think we add value as radiologists, not just diagnosing or describing it, but actually helping them figuring out what surgical approach would be better suited for each patient. Now, just over the last 10 minutes or so, I'm going to talk a little bit about added value that we can do by providing information about renal tumor aggressiveness. It's well known that kidney tumors of different histologic subtypes have different aggressiveness, but they also differ in vascularity, cellularity, and tumor architecture. So clear cell tumors are usually the most vascular tumor, and these are about 70% of all kidney cancers. Papillary is about 15 to 20% of the kidney tumors, and then chromophobes and other variety of tumor types are about less than 5%. We know that clear cell tumor is probably the most aggressive type of kidney cancer compared to papillary and chromophobe subtype of kidney cancer. So this is just an old study that shows that the clear cell had the higher morbidity and mortality compared to papillary and chromophobe subtypes of kidney cancer. So why is this important? Well, as these lesions are detected more incidentally, they're detected in older patients who might not be great surgical candidate. And in those cases, our surgeons want to know what kind of cancer-related mortality that they're dealing with. If it's a clear cell cancer or is it a papillary subtype of cancer. We know the papillary subtype tend to be less aggressive, and if the patient is not a great surgical candidate, they may consider non-surgical options like ablation, like watchful waiting or something else. If the mortality from tumor is going to be more than other health-related issues they have, then surgical approach is warranted, and they will be more aggressive in dealing with that patient's cancer. Let's start with cystic renal cell cancer. It's well known that cystic renal cell cancer tend to have indolent behavior. There are a number of studies now that demonstrate that cystic renal cell cancers have low grade, low stage, and do not demonstrate distant metastasis. They don't recur after surgical resection. And if you think about this, so I think it's really important, here MRI adds a lot of value, is to differentiate necrotic tumors from truly cystic renal cell cancers. Necrotic tumors are aggressive tumors. They have necrosis, they have hypoxia. Whereas cystic renal cell cancer usually have a small nodular enhancing solid soft tissue that's less than 25% circumferentially involving the tumor. These tumors, if they don't have their complexity like hemorrhage or even hyperintensity, then they almost are always a low stage, low grade, and do not metastasize. A necrotic tumor, on the other hand, are aggressive, they will metastasize, they'll kill the patient. So MRI, with the ability to look at different contrasts, allows you to differentiate between necrotic tumor, cystic tumor, and so on. And I think if you ever see a metastatic lesion in a cystic renal cell cancer, look for a source of metastatic disease somewhere else. Because cystic renal cell cancers are really, really unlikely to be cause of metastatic disease and death. And when you talk, as I said, about histologic subtype, the clear cell subtype is much more aggressive than papillary subtype of renal cell cancer. The clear cell subtype tends to be more heterogeneous in appearance on T2 images. It enhances avidly and also heterogeneous enhancement, whereas papillary subtype of renal cell cancer tend to have a low degree of enhancement, a low level of enhancement. They have internal hemorrhage, so these could be even bright, but they're homogeneous. And if we can use these MRI features to differentiate between papillary and clear cell subtype of kidney cancer. So again, this is a right renal cancer that has avid heterogeneous enhancement. It's a clear cell subtype of renal cell cancer. In the left kidney here, there is a T1 hyperintense lesion with a low level homogeneous enhancement on the subtraction images. This is a papillary subtype of renal cell cancer. Again, other tools like diffusion and perfusion mirror imaging can also further improve our ability to differentiate between these subtypes. So studies have shown that papillary subtype of kidney cancer tend to have a lower ADC compared to clear cell and chromophobe subtype of kidney cancer. And so again, if the goal is to differentiate papillary from non-papillary subtype of kidney cancer, ADC does a really good job, has a good cutoff value in differentiating those subtypes. But again, as you see here, there's also a lot of overlap between different tumor types. For example, AML, oncocytoma, benign lesions can overlap cellular renal cell cancer in looking at just the ADC values. This is the graph that shows, this is a table that shows a papillary subtype of cancer has a lower ADC. But as I mentioned, there's some overlap between AML and oncocytoma and benign subtypes, and then tumor vascularity and cellularity both influence ADC. So if you think about it, ADC contains information about both the tumor cellularity as well as vascularity or capillary perfusion. And if you can actually differentiate between the two, maybe you can add more value. So one of the ideas has been that if you perform diffusion with imaging at multiple B values, and if you fit the data at a higher B value, that gives you information about true restriction to diffusion. And the term usually uses so-called DT or tissue diffusion coefficient. Whereas the signal loss at a lower B value gives you information about perfusion or capillary perfusion information that is contained within the diffusion signal. So this is a non-contrast technique that can give you information about tissue, both microenvironment and vascularity. And if you use that kind of information, you're able to start differentiating more different subtypes of kidney cancer. So for example, papillary subtype of kidney cancer has a low vascularity and low DT, whereas the clear cell and chromophobe subtype tend to have higher vascularity. And then the clear cell subtype, which has more heterogeneous and more necrosis, can actually have a higher DT or tissue coefficient because of necrosis than a chromophobe subtype of kidney cancer that does not have as much necrosis. So again, ability to use IVIM kind of diffusion analysis allows you to further improve your ability to differentiate between chromophobe and clear cell subtype of kidney cancer. What's even more interesting is that these tumors may have a mean or median value that overlap, but these tumors are heterogeneous. They have a different, on a voxel wise, if you look at the heterogeneity in these tumors, they are different. And so, for example, if you just look at the problem of differentiating benign lesion like AML and oncocytoma from clear cell and chromophobe subtypes of kidney cancer, if you look at the mean values of FP and DT, they tend to overlap. But if you look at the histogram features or heterogeneity, you find that angiomyolipoma, for example, is much more homogeneous. And you can differentiate angiomyolipoma and oncocytoma from clear cell and chromophobe subtype. And again, some of this stuff is a research arena, but you can start seeing how ability to use these advanced techniques allow you to now separate benign from malignant lesion and subtype them, so it can give you some information about tumor aggressiveness. In addition, not only that you want to be able to differentiate clear cell from a non-clear cell subtype or papillary from a non-papillary subtype of kidney cancer. But can imaging actually help you in differentiate between high-grade high stage and a low-grade low stage tumors? Again, diffusion red imaging has shown some value in doing this. Studies have shown that high-grade tumors tend to have lower ADC compared to low-grade tumors. And similarly, high-stage tumor tend to have much more heterogeneity compared to low-stage tumors. So if you just look at a clear cell tumor, but if it has a much more heterogeneous tumor, it is more likely to be a high-grade and a high-stage tumor. And people are also looking at advanced pharmacokinetic modeling, so it's perfusion red imaging, trying to see if can we add extra value by doing other things like looking at the tumor vascularity better. So when we look at signal intensity, you're looking at over a time frame of say 15-20 seconds. It's average over that time frame. But if you do imaging at a high enough temporal resolution and do perfusion red imaging, you may be able to get more insight into tumor vascularity. And studies have are trying to differentiate these tumors. And what they show is that, again, as we know, papillary subtype of kidney tumor is much more hypovascular compared to clear cell and chromophobe subtype of kidney cancer. But maybe we can actually now differentiate between clear cell and chromophobe subtype, and maybe also between chromophobe and oncocytoma. As I mentioned earlier, the conventional techniques are not capable of differentiating oncocytoma from chromophobe, but maybe some of these advanced techniques allow you to differentiate between oncocytoma and chromophobe. Again, a lot of stuff this in a research setting, but just kind of thinking about the value of MRI and the ability to discriminate between tumors of different aggressiveness. So over the last 25 minutes or so, what I've tried to do is to lead you through what we do today and what we might be doing tomorrow. So our role as a radiologist today include diagnosing and staging renal cell cancer, provide preoperative planning information. As our role evolves, we are trying to do more than that. We're trying to use some of these MR tools to assess for aggressiveness of tumors, and this can provide individualized therapy for patients. Thank you very much for your time.